Well, welcome to episode 207 and welcome back. We're excited to be back up and running today with Crisis Jam and a fireside chat with Dr. John Draper and Dr. April Naturale. April, you've been such a friend and resource and partner for decades, and we're excited to have you on the Crisis Jam today. There have been a number of impacts for states around the country over the last months in particular, but you've been spending your career doing this great work. So look forward to that discussion. We're going to start with talking briefly about the debate that Travis Atkinson and Margie Balfour engaged in back in our most recent Crisis Jam. Really outstanding discussion of crisis facilities should receive voluntary and involuntary referrals. And for those of you who were in the pre-program, we showed a video of Ukaru and its support for working with individuals that might be at higher acuity. This audience of the Crisis Jam, most of you felt like crisis facilities should take both voluntary and involuntary referrals. About 70% of you said yes, or either yes or definitely yes. The most common response was yes at 36%. But Travis definitely moved some of you, as Margie and Travis didn't focus so much on whether crisis facilities should do this or not, but on different types of crisis facilities. And Margie talked about the Arizona model of emergency behavioral health crisis receiving facilities. Travis focused it more on crisis residential, crisis respite, and other kinds of peer programs as well. We're going to follow this discussion thread further in an upcoming Crisis Jam in a few weeks in episode 210 with one of the pioneers behind this idea of no wrong door that emerged in Texas and Arizona back 15, 20 years ago now. So we'll be talking to Dr. Chris Carson, and he was in one of our earliest Crisis Jams back 5 years ago. Richard McKeon, it's been a minute since we first launched this. Of course, that was back during a Trump administration. Here we are back in another Trump administration. But Dr. Chris Carson in one of those early programs will be back with us in a coming week to follow up that debate discussion. And we've got more debates coming your way in Crisis Jam 2025. So you're going to want to be here. Mobile crisis should always be dispatched by the local 988. Justin Chase and Preston Looper are going to take that topic on. And of course, Preston and Matthew Goldman engaged a national survey around mobile crisis at the direction of SAMHSA. And Preston found that about a third of the time currently, mobile crisis is dispatched by 988. All states should enact legislation that includes a 988 fee, similar to how we pay for 911. We've got what is it now? 8 or 9 or 10 states that are doing that currently. Tom Betlock and Hannah Wesolowski are going to take opposite sides of that approach. Hannah's going to encourage the model legislation, and Tom's going to talk about a different way to do that. We're hoping to have that on May 14th. As always, to keep abreast of what's coming to you in Crisis Jam or to see that most recent debate, go to talk.crisisnow.com where you can see the video, the trivia hot seats, and so much more. The Crisis Jam over these 5 years has had over 500 unique presenters, people who've been engaged. They've been in the round table. They brought you a featured presentation. Giving you a lived lens, a Medicaid corner, a peer front and center. There's been a host of things. Today, you see April Naturale's name in yellow there, right in the middle. I actually don't believe somehow April's never been a presenter, and this is her first time. So we'd love to have you, or if there's a topic that you'd like to see us engage, don't hesitate to share with us. In terms of our news for the week, we want to start off with a huge thank you to Monica Johnson. And I'm going to show on the screen here the kudo board that some were sharing about in order for people to have a chance at writing their own comments for Monica. I wrote on here, Monica, your leadership and vision have been nothing short of extraordinary. In less than 2 years, you've helped shape 988 into a lifeline that truly embodies care and compassion. Your infectious positivity and ability to bring people together have set a lasting standard for crisis care. Wishing you all the best in your next chapter. You leave behind an incredible legacy. So huge thanks to Monica. We've known Monica for years of her leadership in the state of Georgia, coming to SAMHSA and now going to HMA Consulting. Great work by Monica, and look forward to keeping in touch with her. And Monica, I don't know, is Monica in our Crisis Jam today? Monica, jump in here if you are and say hi. Our next news item, of course, President Trump gave the State of the Union address last night, and it talked a lot about all the activity. One of the things he's done among the executive orders is following up one of the ones he did in 2019 to build on it around transparency in pricing in healthcare. And actually, Becker's Hospital Review gave us these 5 things to know about the order, which directs HHS, Labor, and Treasury departments to rapidly implement and enforce healthcare price transparency enforcement. You see in the number 2 bullet here, to make prices comparable across hospitals and insurers, including prescription drug prices. This will ensure that hospitals and payers disclose actual prices, not estimates, and take action. For those of you who aren't in the provider community, or if you're a funder, it's very frequent that we can't see how this works or what the rates are from provider to provider. There's a lot of secrecy around this. And this order requires hospitals to publish prices that reflect what people actually pay for services in a way that's clear, straightforward, and accessible to all. So we'll continue to track that as it develops. So if you were in the pre-program, you've got a leg up here. But if you aren't, let's get your best guess at our crisis trivia hot seat of the day. UCARU is a restraint-free training program to manage aggressive behavior. So again, Margie's talking about a crisis facility that takes both involuntary and involuntary, voluntary and involuntary individuals. UCARU reframes these aggressive behaviors as survival skills that guests have learned over time. And our job in crisis is to end the escalation. So UCARU is a program that focuses on engagement, relationships, trauma-informed care, and includes a key use of what? If you weren't in that pre-video, is it quiet rooms, soothing sounds and natural light, karate-style blocking pads, or safety officers focused on the milieu? April, you were referencing in the pre-show that you've run a program before. I've seen all of these different kinds of quiet rooms, soothing sounds. I've seen safety officers focused on the milieu. What did your program do to try to help with individuals having these big kinds of feelings?
Well, as you mentioned, we used all of these things. We actually did have quiet rooms, but we always kept the doors open so people didn't feel, restrained, and did a lot with light and natural light, with pets, with greens, the different kind of environment. But we did also have specially trained, we didn't call them safety officers, but the staff who were trained in making sure they take a step back and not do this threatening approach when somebody's in a really upsetting situation. So we used a lot of these different types of techniques, but it sounds to me from the video, I did get a sneak peek, that there's even more to what UCARU offers.
So UCARU is a use of karate-style blocking pads. Now, it does have a strong focus on engagement and trauma-informed care, but it was developed by Grafton Behavioral Health, which ran youth residential programs, and we're seeing a very significant number of injuries to both guests and staff in seclusion and restraint activities. They developed this approach, which they now have as a product that they market to a host of different types of organizations. April, what was your reflection on seeing that in action in that video? And we'll share the link to that video for those of you who aren't in the pre-program.
It's very impressive. And what I think it showed too was something that we don't talk about, which you mentioned, David, is that very often the staff do get hurt. We're of course very concerned about the clients in our care, but it's not unusual when someone is really in a crisis that they can, certainly mistakenly injure a staff. And so I think it protects everyone who's involved in a crisis situation.
And that brings us to this chat. Dr. John Draper sort of teed it up a bit here. You and I have been working together with April for 20 years, you a little bit more even, I think. And lead us off here, John. When did you first meet April? And how has that relationship worked together as you led the development of what is now the 988 Suicide and Crisis Lifeline, and April led the Disaster Distress Line?
Yeah, it's actually a century-long relationship I have with her. It started at the beginning of this century. I first actually hired her as the network development director for the Lifeline back in 2004. She was the first one. And April also directed the Oil Spill Distress Helpline, which is now called the SAMHSA-funded Disaster Distress Helpline. That was since 2011. And then she consulted on an NFL Lifeline project. She was hired back at Environment about 7 years ago, where she's now the VP of Disaster Services. But since 2001, David, April has become, I think, perhaps the most visible and influential leader in disaster mental health care in the world. We first met, again, during 9/11 and Project Liberty. And before we talk a little bit about that, April, I got to note, 2025 is off to a rip-roaring start with the mass vehicular homicide attack in New Orleans and the devastating wildfires in Los Angeles and now North Carolina. These last several years, before and after the pandemic, we've seen a lot of catastrophes. Are we seeing more disasters this century, or more media about them, or both? What do you think?
Oh, I thank you again for the introduction and the opportunity to be here, both David and John. It's been an incredible journey. I can't believe it's as long as it is, John, but it's been really good work together. And that's why I think we continue to do this, right? I think the answer to your question is absolutely both. There is an increase in weather-related disasters, not only here in the U.S., but across the globe. We've heard the UN talk about this. We've certainly seen it here in the U.S., both small and larger scale than we've ever seen before. But media and social media makes this information immediately available. And as disaster behavioral health folks, we're concerned about that because, it is exposure to traumatic events like this that is the change agent that can increase our risk of developing a mental health problem or being able to cope better and move on to recovery. So we're concerned actually about both the events happening and being able to support communities, but we also want to protect people from the overexposure that we're getting in the media and especially in social media today.
Boy, that was a huge issue in 9/11. People actually saw the plane go into the second tower after seeing the first one on fire. And New York State's Project Liberty Crisis Counseling Program, which was established back then, the largest ever, I think, and it's now coming on its 25th annual remembrance in 2001. That tragedy, April, was our introduction and perhaps America's introduction to the need for disaster mental health services. I wondered if you had a story or an example from that experience that illustrates why disaster mental health services are so important for community recovery after a disaster.
Oh, goodness, we could probably stay here all day and talk about stories. There's
Good.
one after another after another. And I had been a crisis worker even prior to 9/11. And so it was astounding. And it was really quite interesting for us to see and to learn how impactful these disaster mental health programs could be, from being uptown where communities are on the streets, hanging around, talking to each other outside schools, places of worship, and the crisis counselors. We had 4,800 local folks work in Project Liberty as crisis counselors, doing outreach in all the boroughs, going up to people and checking in with them and seeing how they were doing and if they needed anything, doing our monitoring and surveillance to make sure that people were in a stable place, but did they have resources that they needed? How were they coping, and what else could we do to help them to get onto a recovery path? And people would say incredible things. First of all, they were open-hearted and they would easily talk to strangers, right?
Yeah.
This is always the thing to me that is so outstanding, is that when we show caring and compassion for people, they're open about it and they were willing to talk, they were willing to engage. They would say things like, wow, somebody from the government is asking us how we're doing. That's never happened before. We heard from young people up in the Bronx that, yes, they, of course, were unhappy about the terrorist attacks, but they also opened up and shared and said, what we'd really like help with is doing some problem solving and conflict resolution, because we're living in some neighborhoods where we're sleeping under our beds at night because of bullets. And so they really started to share what their concerns were about how they were managing emotionally, as well as in other practical ways. And the one thing that really struck me as I started to respond to more and more mass violence events was talking to families and being in community forums and just being really open and honest and saying that I'm really sorry this has happened to your community. This is such an awful thing. It shouldn't be happening in our communities. And every time we reach out with that kind of compassion and caring to people, they say, oh my goodness, nobody's ever said that before.
Right.
Wow, somebody's concerned about us. And so
Yeah,
it's a giant impact.
that sense of why us, why now, why our community, and just saying to them, it really shouldn't be happening. And as we note, there's a varying responses to these highly catastrophic events. Some people having more acute stress and others traumatic ones that last longer. But how do disasters and unstable environments impact our mental health? I mean, what factors play into enhancing emotional resilience and recovery, or on the other hand, what makes people more vulnerable to having these longer term mental health effects?
Yeah, there are lots of variables, John, but as we know, trauma is about the fear response. We're afraid. We're going to get killed, we're going to get hurt, or someone that we love or that we care about may get hurt or get killed. And so we have these kind of automatic responses of being defensive, of wanting to fight, of getting angry. But the truth is that 80 to 90% of people actually get on a good recovery path in a fairly reasonable amount of time with good coping, which are basics, taking care of yourself, talking to others who care about you, who understand and accept how you feel, exercise, getting stress and adrenaline out of your body. That's good coping and good social supports, being with others and not isolating. And as we know in the suicide prevention world, that's a high risk, a red flag. So we're always concerned about that as well. But obviously, when I say 80 to 90% of the people do well, we're very concerned about one person who may be at risk of developing something like post-traumatic stress disorder or major depressive disorder. But we see in natural disasters that about 90% of people do well without any formal mental health services. In mass violence, in incidents where there is intent, human intent to harm, the numbers drop, and we see about 80% of people do well without formal mental health services. And what the researchers have told us is that has a lot to do with our difficulty in making meaning and understanding how one human could treat another human that way. We're more forgiving with nature, and we understand natural disasters, but less so how people could be cruel to one another. But again, we're very concerned about any number of people. In large-scale disasters, 10% or 20%, could be hundreds or thousands of people that we want to monitor and see if we can mitigate them going on to develop a mental health problem by offering that compassion, that care, teaching them some good coping skills, and giving them some good resources.
That's really interesting, that difference between natural versus human-caused impacts, and what is more likely to help or hinder recovery. In this case, what you're describing too, I think, with human-caused catastrophic events and acts of violence, is that sense of trust, that sense of safety. I mean, we've been living with Mother Nature's impacts all our lives, and but that sense of the social environment, the very place where we look for support to feel safe, suddenly doesn't feel that way socially, and to the degree that people might then be suspicious. And I remember after 9/11 saying,
Mhm.
is this what we're going to have to is this what we're going to have to live with from now on? That every time I get on a subway, every time I'm in a high building or anything, that I have to worry about this. But what's interesting is that that didn't occur. But what has occurred is what happened following the Columbine attacks, is that we saw, so many more of those, and they've become ubiquitous in these mass shooting events. And I wonder about the impact on our kids, April, and growing up in a chaotic world now with little life experience beyond these disasters, which do seem to be there constantly. What can we say and do for our kids to give them hope and build resilience?
Well, as you know, John, hope is major priority. We must be able to give each other hope to have hope, and certainly to pass that on to children. One of the primary things we do is to help adults, because as adults, we tend to underestimate the negative impacts on children. We think that maybe they're not really able to understand or they're not really listening when they are overexposed as well, and they talk to each other and they may have misinformation. So we want to understand, we want to know what they already know. We have to ask them about these things. We want to get a sense of what they make of it. But we also want to engage them in the fact that they have some control over this. Kids are pretty good problem solvers, right? And they tend to be able to help each other and do things together in ways that we as adults, may have closed ourselves off from. So we teach them that their job is still to learn and to play, right? We don't want to give them adult
Mhm.
responsibilities. We want to make sure that they're still having a sense of connectedness to their
Yeah.
families, to their
Yeah.
friends, and that they can still have joy despite all these disasters and these horrible things that they're seeing on television or hearing about from their friends. But truthfully, I think when we go back to basics about teaching them how to look after each other, like
Yeah.
like those of us who are in big families with siblings. I had three brothers. I always felt safe, right? They always looked after me. Teaching them to do this in school, how to look after each other, and how
Mhm.
to like check in with their own families, be
Yeah.
able to talk to somebody in the family, talk about their feelings, their dreams, their fears, and help them to learn how to compromise, how to problem solve, and how to work with other kids in ways that give them, again, more joy and letting go of distress and adult type responsibilities. And I think kids do that much easier than we
Yeah,
do.
yeah. But I think the important point you're making is that no, we can't do. And I remember asking myself, I can't do anything. I mean, how do I stop these terrorist events from happening? I know I can't do that. But what can I do? And I've never dealt with something like this in my life. How do I deal with that? And how we deal with it is, it's like, well, how do you deal with anxiety? How do you deal with fear? How do you deal and you, so it's a lot of the same coping skills that we took. And so just
That's right.
teaching our kids to do that. And you mentioned how important social support is. And I remember probably the biggest lesson I learned from, well, there's a lot to be learned from 9/11, but in that disaster response was that we need two things. We need social support is so important to be maintained, and also routine, regularity, that with all the chaos strewn about and the unpredictability, that we have some routine and regularity that can ground us and anchor us through these difficult times.
That's right, John, because just as our bodies respond to fear and the threat of being hurt, our bodies also respond to that routine. I always use the example of people saying, after some kind of an event, they don't want to do the things they normally need to do. They don't feel like it. And I
Mhm.
say, yeah, but you may be griping and complaining. I have to go back to work. This is awful. And you get to work and you're not happy about it. And you sit in your chair and you're still griping, but your body says, oh, I
Yeah.
remember this,
Yeah.
and there's a sense of, familiarity and
Yeah. Yeah.
relaxation. You might not last the whole day, but you've made it
Yeah.
through part of it, and your body starts to feel comfortable with that familiarity. This is
It's true.
especially true for kids, but we do absolutely benefit from that as well. And
You were talking about, I was going to say, you were talking about fight and flight and freeze and all that with that is the body's response. And you're so right. The body is also looking for safety and signs of safety. And what it sees with familiarity and regularity is normalcy and
mhm.
safety.
And that's why it's important for us to continue our routines as best
Yeah.
we can. I do also talk about adding new ones, things that you may not have done before that might help you. I was talking with a client just a couple of days ago who said, my old coping skills just weren't working as well. And so we started to talk about different things. So being open is really helpful. And I did want to bring in that actually the research, George Bonanno has studied resilience. It's become kind of a more common word than it was in the time of 9/11. But what we learned is that actually more people get some kind of a strength from going through traumatic events. And you hear people talk about this all the time. Maybe they learned to be more appreciative. Maybe they learned they were stronger than they thought they were. Or they've learned things like gratitude, which can change your brain cells.
Yeah.
Really
Yeah.
powerful things. And actually, that we call it post-traumatic growth. And you'll see in the research that actually many more people experience that than they do a mental
Mhm.
illness. And this is an important message because if people think they're doing poorly, like running around saying, "I have PTSD, I have PTSD," when they don't know if that's the case they don't do as well as people who have a sense of self-efficacy.
Yes.
Okay,
Yeah.
I have some good skills. I have good social supports. I know how to take care of myself. These are the folks who do better.
Yeah, I can do this and I'm capable in situations that challenge me, help
Yeah.
you feel safe. Well, and April, I mean, I've seen you over so many years going to, I mean, you were in El Paso, you were in Las Vegas, you go to hurricanes, you go to tornadoes. And if anybody, needs to talk about self-care, I would imagine you would, because I often wonder how do you take care of yourself? I mean, how many of these events have you responded to over the years? And how do you take care of yourself?
Mm. It's a great question. All of us who are responders, who are mental health practitioners, those of us who go out and help other people, we usually put our own needs last. And I learned the hard way. I suffered a lot because I did not take care of myself when I started doing this work. So I actually do everything. I try to implement any way to do anything that can help with self-care. But I do start with scheduling things because for somebody like me who does work around the clock at different times, and the time zones and different countries, you could be working constantly. So for me, the old cognitive behavioral therapy rule of scheduling things really helps. So I schedule walks, being physical, being out in nature are really important, or on the treadmill, however you do that. Breathing exercises, one of those do no harm types of exercises, and lots of body movement. That's why we talk about doing stretching exercises that open up the heart area, right? And stretch all of these places that we hold on to, these muscles that get tight as we sit at our computers or we're on the phone. But sleep is the number one issue people complain about, whether you're a child soldier in Uganda or whether you're somebody who was impacted by the NOLA vehicular shooting event or a flood or a fire, frightening types of events. Everybody complains about sleep problems. So you implement what you can, from earbuds to eye masks to soothing music,
Yeah.
affirmations. Use anything and everything that works to help you get good rest, and make sure to connect with others, because the research that social support helps more than anything is really through the roof.
Amen, April. And I know we're going to put some in the chat. We're going to be putting in some resources, but I just want a couple of notes of gratitude here. First and foremost, I'm so grateful for you and for all of the years that you have given us and people in communities around the country and around the world who've been impacted by disasters. You are a gift to all of us. And I also want to say the Crisis Jam is a gift to all of us. And I'm so glad we're back. I'm glad we're jamming together again.
Mm. It's
David?
been a privilege for me working with all of you and in every community. So thanks for the opportunity to talk about this.
Thank you, April.
Yes, thank you, John. Thank you, April. John, you and April began working together in the wake of 9/11. April, you, John, and I began working together in the wake of Hurricane Katrina and its impact nationally. But let's go to our roundtable. And Sandra Koifman, Dr. MBA from River Spring Health and expert in this disaster work as well.
Thank you, David. And I'm so glad to be. Actually, no, I'm actually a little bit terrified to be following April, but so glad that I've had a chance to really learn from her along the way. I'm proudly wearing the Liberty, the dependent April shared with me some years ago, and I've had a chance to work with John as well. We were just reminiscing in the prep about our conversation quite a few years back about how amazing would it be to integrate psychiatry and psychiatrists into adequate response post-disasters. And wouldn't it be amazing to integrate disaster psychiatry outreach, the not-for-profit that I was running at the time, into what Mental Health Association of New York was doing and disaster distress hotline. Fast forward, of course, Vibrant and DPO came together into an integrated solution that now is Crisis and Emotional Care team that April runs at Vibrant as part of her book of business there. And it's quite an amazing way to have an interdisciplinary team that not only answers what to do right here, right now, how can I, as a healthcare provider, be part of the response, but also what happens when I'm no longer available to be here, post-Katrina, post-Superstorm Sandy, and so many others. So it's been quite a journey to now be on the board of Vibrant and see how we are thinking about how important disaster response is to be part of the integrated services. So it's been quite a journey and just really glad to be here.
Thank you so much, Sandra. Appreciate you joining us today. Dr. Richard McKeon, crisis services have run up alongside these disasters. Of course, when Katrina hit and we were all working together, ViaLink went down. The Baton Rouge Crisis Center actually Baton Rouge went up because we had the Houston Crisis Center, I think, went down as the impact was roiling and we were all. So Richard, your reflections on this discussion and both the current and historic issues.
Thank you, David. This certainly brings back a number of memories, including, I'm sure, virtually everyone remembers where they were on 9/11. I was at the U.S. Capitol, and we were evacuated immediately after a plane hit the Pentagon. So it was obviously just a terrible day. The Pentagon does have now, and has for a number of years, had a memorial both inside and outside the Pentagon to those who were lost that day. And then you also talked about Katrina, and Katrina was something I was more engaged in directly in terms of the response. I was deployed by SAMHSA down to Louisiana for 3 weeks. As you mentioned, our center in New Orleans, ViaLink, was flooded out and needed to close and to relocate up to Baton Rouge. And the Lifeline put out a request for volunteers and funded volunteers to come to help provide the staffing for the center relocated now to Baton Rouge for that period of time. Another really important piece of what happened then was that there was a recognition that there needed to be a place to call for the mental health consequences of the disaster. And what was most available at the time was the National Suicide Prevention Lifeline. And so what we did was to change the message to make it clear that that it was still available, of course, for people at risk for suicide, but that it was also available for emotional support to those impacted by Katrina. In fact, I think it might have even been April who did the recorded message. But one thing we learned from that experience was that there were complications in using a line that was that had a focus on suicide prevention for disaster mental health. Sometimes people would call and they would say, well, I'm not suicidal. This isn't for me, even though the recorded message did directly, indicate that, this is for those who need support following Hurricane Katrina. And it was from this experience that led to SAMHSA's awareness that there really needed to be a disaster distress helpline that was not identical with the then 1-800-273-TALK number, but could really be focused specifically on those needs. And that was what led to the disaster distress helpline that has now been with us for a good number of years and done such tremendous work.
April, Sander, John, Richard, thank you so much. Great presentation. And the exposure that social media and the news media bring of disasters we wouldn't have known about in times past, maybe a topic we want to explore further, April.
For sure.
Thank
David.
you.
Thank you.
And back to King Richard, our crisis leader, grandfather of crisis mental health, Dr. Richard McKeon, our SAMHSA update.
Thank you, David. And again, so glad to be here. I'll just quickly mention a couple of things. The president has not yet nominated a assistant secretary for mental health. But we do have current excellent leadership. We have a deputy assistant secretary for mental health. His name is Christopher Carroll. For those of you who have really long memories, such as myself, or have been around for a long time, may remember Chris when he was the special assistant to Catherine Power when she was head of the Center for Mental Health Services. And that was when I first met and worked with Chris. He later went on to other roles within SAMHSA, and more recently was at the Center for Medicare and Medicaid Services, and he has now returned to SAMHSA to be in the role of deputy assistant secretary. Just a couple of other things. A notice went out from Vibrant earlier this week that the final major telephone company has implemented geo-routing, and that's AT&T. So this is another important step. All of the so-called big three telecom companies have now completely implemented geo-routing. There are some smaller companies that need to still working to join as part of the FCC's order. But at this time, the overwhelming majority of calls coming into 988 get geo-routed. And just as a reminder of what that means, that for cell phones, and of course the problem had been that cell phones are being routed by their area code, not by the person's general location. With geo-routing, as the information flows through the local cell tower after the call is made, geo-routing allows the call to go to that general area. So again, it's not the level of very specific location that 911 has to know exactly where someone is who don't, but you know their general locality. So this means that if I'm in Los Angeles and I call 988, rather than going to Everymind in Rockville, Maryland, it will go instead to Dee Dee Hirsch, where I would be physically. And then the final thing I would mention, and some of you are likely aware of this as well, but about a month ago, the National Emergency Number Association released their standards for 988 and 911 collaboration. It's an excellent document that has been in work for a couple of years and is now out. And I actually think that that it would be a great crisis jam to perhaps, do on the NINA standards and the relatively recent SAMHSA document on when to call 988 versus 911. And so I'll just mention a couple of other things. Tom Coder remains at SAMHSA and is working closely with Chris Carroll. So that is our leadership chain at the moment. John Palmieri, who was previously acting director for the 988 office, is again in that role. And regarding geo-routing for text, FCC has initiated a process for that, but that is not currently widely operational, but it is for phones. So I will stop there.
Terrific, Richard. And let's follow up. I know you and I had a discussion about a presenter for that the work between 911 and 988. Let's follow that through, and as you said, get them on the crisis jam. So we've got the SAMHSA update. Let's now go to the states. Dr. Deb Peinels with NASBID.
Yeah, hello all. Great to see everybody here. Great to hear April and all the other people that joined, but it's just a wonderful opportunity for us to be together again. I want to talk about disaster behavioral health from the state's perspective and think about some of the things that we've learned through these. We work at NASBID with the state mental health leaders, and really some of the things that we have to keep in mind more than just at the individual level is addressing the needs of people with serious mental illness, youth with serious emotional disturbances, people with intellectual and developmental disabilities and substance use disorders in the context of disaster, their unique needs that they may have that have to be attended to. We also have a role of thinking about the needs of the entire population's mental health. That's somewhat of what April and John were dialoguing about, and really thinking about the before and during and after disaster responses, and providing supports and making sure that infrastructure of supports are there. And that's why preparation and is so important. And then finally, just really thinking about the workforce needs, because we know that the workforce that is impacted, we're all humans as we are impacted by disasters surrounding us, and we're there to help. We have to think about our own needs and our workforce needs. We know that in emergency management, there's preparedness, prevention, mitigation, response, and then recovery. And each element is something that as state leaders, state behavioral health leaders, we participate in with partners in thinking about this. And this is why the conversation with 911, 988 is so important. Next slide. As we think about the component parts for state leaders, the COOP planning, the continuity of operations is so critical. We have to make sure that we have done our tabletop exercises to make sure that we are prepared for whatever type of disaster. We talked about humans doing things to humans. We talked about natural disasters, all the sorts of things that might come up and all the needs. We still have to maintain our operations. And that requires having knowledge about how we're doing community outreach and prevention, thinking about what mental health service demand will look like. And the state behavioral health leaders are often thinking about state hospitals, the community treatment services, especially residential settings, and even what happens in correctional and forensic systems for populations. Impact on crisis systems, impact on finances and the financial demands that come with the disaster, making sure that we have medications available for people. I can remember working during the Boston Marathon bombing and different things that were happening and different blizzards even where we had shutdowns of just making sure that we had medication access for people who need daily medications. Communication and coordination is critical. Technology and the infrastructure of technology, again, special populations that we have to attend to, the unhoused, youth, our youth, and the impact of the disaster on our youth who may have families, may not have families. They may be in the child welfare system, in the JJ system, as well as again, individuals with IDD and older adults who may have unique needs and may need special support services, medications, devices, technological devices that help people be able to communicate and the like. And that means we have to think about our policies and operations and then partnerships and alignment. So these kinds of conversations are really critical to think about who do we have at the table to make sure that we have that continuity of operations planning going well for the behavioral health needs. Next slide. So NASHBID is here to be a partner at the table, and we're really thrilled about that. There's some resources. Of course, the SAMHSA website on disaster response is the key resource that you want to turn to, and really feel free to reach out to any of us at NASHBID as issues come up that maybe we can help with. And I'll end there.
Thank you so much, Dr. Finals. We were talking debates at the outset of the program, and of course, one of our first debates was Dave Atkins and John Draper around artificial intelligence, which birthed this Tech Corner. Dr. Tina Soma, welcome.
Hello, thank you so much for having me. I really appreciate it. I'm going to jump in and share some slides with y'all and talk super briefly about a couple different types of artificial intelligence. I'm just going to focus in, again, very briefly on prediction and classification AI. And what I want us to start with, I'm going to borrow a metaphor from the authors of AI Snake Oil. If anyone is looking for a really kind of educational, easy to read book about AI, I can't recommend this book enough. What if we lived in a world where we didn't have different types of words for transportation? So maybe everything was just called a vehicle. So I might be talking about how vehicles could be allowed on sidewalks. I want to talk about trail maintenance for my vehicles. I want to talk about how the government should subsidize my vehicles. And maybe someone else is talking about the speed of vehicles, safety of vehicles, how many folks can we take into space with our vehicle? And we get to a point where we're talking about, I can't take a bicycle to space and I can't take a spaceship to work. So what are we really talking about here? And what the authors assert is that what happens if we put the word artificial intelligence in for the word vehicle, and that explains some of the landscape that we're in right now. There are so many different types of artificial intelligence. We hear language like machine learning, we hear natural language processing, we hear predictive AI, we hear classification AI. How are those all different? And what does it mean in terms of how valid, replicable, generalizable that they are? how dangerous they might be if used inappropriately, and what types of technology do we use every day that we don't even maybe consider AI just because we use it all the time. So one example that I really like to use for classification AI, again, we're organizing data into categories that we've already defined. Our spam filter. Our spam filter is a type of AI that we might even not consider to be AI because we've been using it for so long. That's something that AI is really good at, is classifying what we have defined as labels. We've provided data. We're really good at that kind of problem. Predictive AI, and something that the authors of this book really focus on, is a task that we have a lot of issues with, where we're taking historical data to make decisions about new data. Some of the problems with that is we often don't have enough data available. They go into this question of, we might need more data than there are people. That's called the 8 billion problem, which I think is a really interesting aspect of what are large language models really made of and what are they doing. We might not be using the right features to make predictions. There could be millions of features that we're using to make predictions about, are people going to get sick? Are they going to need help? Are they going to be delinquent on their taxes? We just might not have enough information about what those predictions are. And prediction is a task that's really difficult for humans too, which means it's also going to be difficult for the models. So again, this is a really fabulous resource as we're really trying to navigate the landscape of AI. There's so many different types out there. There's a lot of urgency, demand, and I would encourage you all to really slow down and take a breath and think like, okay, if we're talking about this as we're talking about vehicles, am I talking about a bicycle or am I talking about a spaceship? Let's slow down a little bit and try to make some good decisions about that. So again, thank you so much for having me. And back to you, David.
Wow, Tina, let's get us back to sharing. Terrific, Tina. And these are topics, we want to slow down, and all of this is moving so fast right now. So we'll welcome you and your team back, Tina, to learn more as this continues to change our world. You saw the Super Bowl commercial about the two kids in the little market, and they were talking about the computers and then the AI. Did you see that?
I didn't, but I need to go watch it.
It's changing our whole world. Okay, so more on that to come, but now let's go to our federal update. Sarah Corcoran from Guide Consulting and Joanna Rosen from AFSP has now moved to NAMI. We hope she'll continue to be part of our program. Joanna, if you're here, say hi in the chat. But Emily Feltrin, welcome. Glad you're with us, and look forward to an update from the two of you.
Well, I echo the thanks for all the updates from Joanna over the years, and really excited to work more with Emily on this. I'm going to give a quick federal appropriations update for FY25, and then I will turn it to Emily for some additional Hill updates, but kind of where we are in the process. Some of you may recall from a previous update, the current continuing resolution keeping the federal government open and funded will run out at midnight on the 14th of March, going into the 15th. So we've gotten some indications from Speaker Johnson that he plans to release a additional continuing resolution to keep the government open and funded through the rest of this fiscal year, which runs out at the end of September. There could be some plus ups from what we've seen in defense spending, but keeping things kind of relatively stable at the FY24 level, which is what we are currently operating on. There are some, besides the time crunch, challenges to getting bipartisan support in both chambers on that approach, and they are working through that process to see if they'll have enough votes to pass it out of the House and then the Senate, since this will require bipartisan support from both chambers. So we are running a little close on time, but hopefully we can keep the government open and funded and avert a shutdown, but some more work has to happen on the Hill and negotiating before we have an indication of what will happen next. Emily, I will turn it to you.
Thank you so much, Sarah. And thanks for the warm welcome. Really happy to be stepping into the big shoes that Joanna left me as she moved on to NAMI. So just a couple of things. I'm Emily Feltrin, Senior Director of Federal Policy and Advocacy at the American Foundation for Suicide Prevention. I wanted to share a couple of updates about nominations. So in the last few weeks, the Senate did confirm Robert F. Kennedy Jr. to be Secretary of the Department of Health and Human Services, as I'm sure many of you are aware. That happened on February 13th, and the same day the president issued a new executive order on establishing the president's Make America Healthy Again Commission. Otherwise, today on March 5th, the Senate Health and Education, Labor and Pensions, or HELP Committee held its nomination hearing to consider Jay Bhattacharya to serve as the director of the National Institutes of Health. And then tomorrow, the Senate Help Committee will hold a hearing on the nomination of Dr. Martin Makary to serve as the head of the Food and Drug Administration. So all things that we're watching, and I'm sure we'll have further updates. Quick legislative update that Representatives Jay Obernolte of California and Debbie Dingell of Michigan did reintroduce the bill to prevent outages of 988 and report on cybersecurity called the 988 Lifeline Responsibility Act, and that is HR 912. It was unanimously passed Congress in the House, the last Congress, and it is bipartisan, has been referred to the House Energy and Commerce Committee. I'm sure we'll be chatting more about that in the future. Thanks for the opportunity to provide the updates, and I will turn it back.
Thank you, Sarah. Thank you, Emily. Lots going on, more to come. But now let's go to Crisis Talk. Stephanie Hepburn, tell us about the Aloha spirit in mental health.
Thanks, David. So I'd like to welcome Kathleen Merriam. Kathleen, you helped transform Hawaii's day centers into statewide clubhouses. Can you tell us a little bit about how you did so?
Well, aloha, everybody. Great to be here. Yes, a few years ago, I was working at Fountain House in New York, which is the oldest and largest clubhouse. And Hawaii folks contacted me about wanting to transform their day centers, various, drop-in and kind of traditional day treatment models into clubhouse. And so we began doing some training, and they were coming to Fountain House for the training program, and that's where I was the international training director. And I started coming out here to Hawaii as well. And we began implementing the clubhouse model. So if you don't know what the clubhouse model is about, it's basically a psychosocial rehabilitation program where members of the club run the program together. And this model is in about 36 countries. There's over 300 clubhouses worldwide. You really have to visit one and take a tour to kind of understand the environment. It's a very healing environment where people, are doing things together. Hawaii really believes, and it actually fits very nicely in with the culture here. So I live here now, and we find that this model really fits. And so it's really our model of choice for psychiatric rehabilitation.
Kathleen, you talked to me about your own experience, and if you could talk a little bit about that, and also how that, when you were implementing and transforming the model, the day centers into clubhouses, how did that lead you in your own leadership in that transformation?
Well, my own personal experience, my journey with mental illness myself, I found that some psychiatric hospitals and day centers were not good. And we didn't talk about trauma-informed care back when I was a patient. And I found it very traumatic. I always dreamt of better places. And so when I found Fountain House, I thought, oh my gosh, this is a place that is what I thought would be ideal. And I fell in love with it. And so that's what I now promote, is any kind of place that has an environment where people are working side by side. They're not patients. And so, yeah, basically my own history with bipolar and seeing services from a patient perspective has led me into a life where I want to have mental health services better. And so fortunately, I'm in a role where I can do that here in Hawaii.
Yeah, you said something, you talked about how Yeah,
So
sorry.
Stephanie, thank
Yeah.
you so much. I think we're running short on time. So
Got it.
we've shared the link to the article in the chat, and thank you, Kathleen, for joining us.
Oh, thank you so much. Aloha.
Next week, the Crisis Jam is back, and we've got an outstanding lineup coming up for you. Dr. Belina Shaw will present on the revised National Crisis Guidelines. There have been new service definitions and a mobile crisis toolkit that's out for public review. So we'll get that from Dr. Shaw this coming week. And in 2 weeks, we're going to have our first live and on location. The Huntsman Mental Health Institute, last year in Crisis Jam, we featured Kevin Curtis talking about this amazing new crisis care center. Margie Balfour was talking about an emergency behavioral health facility that receives both involuntary and voluntary law enforcement drop-off that bypasses the hospital medical clearance altogether. That's launching this month in Salt Lake City. All we've seen to this point are architectural drawings, but we're going to take you there live. And it's our first effort to do a Crisis Jam in the same tone and spirit that we normally do, but from a venue. So we're hopefully going to do this again in the future, but we're going to start with Salt Lake City in 2 weeks. So thanks for joining us, and we'll see you next week.